Hey everybody, I'm Nina Crowley. I'm Sika's professional affiliations and education manager, and I'm here today on In the Know with Nina to talk with my friend, Dr. Elizabeth Pash, who's a fellow dietitian and colleague of mine.
Hi, Nina. Thanks for having me. This is exciting for both of us just to make this official and get together and have this conversation like we do every week anyways.
I know. Well, I know after seeing you twice in the past month at our annual dietitian meeting down in Orlando, and then at the OMA obesity medicine meeting in California, and hearing that you would also be at Obesity Week for the Obesity Society meeting, I thought it would be a perfect person to sort of chat with about what we're looking forward to at this conference. And as a new doctor, I thought, our PhD dietitian group is an elite group, and I thought it would be great to talk with you about some of the science that we're looking forward to hearing about, as well as the practice at this meeting.
Yeah, I love that idea, especially since it's the conference season right now. And I feel like we're definitely on the circuit. You see the same people sometimes at all the conferences, but it is really unique, obviously, that we're professional colleagues, but we've developed a friendship to see the PhD, RD at all of these conferences. And they're all a little bit different. And so we have one more coming up and looking forward to seeing you there and engaging with all the thought leaders.
Yeah, and the Obesity Society group has not had their in-person meetings since COVID. So I think
Right.
all of these firsts for the conferences in person have been especially exciting for me. So I think this will be a good meeting. So I know I've got a couple sessions that I've highlighted, and I thought we could talk actually about one of them that incorporates our dietitian and our sort of scientific colleagues with the weight management dietetic practice group. So that's a group that we're both part of and have had leadership within. That's under the umbrella of the Academy of Nutrition and Dietetics. And so they do a symposium where they partner with the Obesity Society. And this year's I'm super excited about the topic. It's on flexibility and low structure diets in eating. It's got a few of our notable colleagues. I know Holly Rayner is always a fantastic speaker, and she'll be able to shed some light on this. Have you looked that one up, or have you kind of been excited
Yes,
about that one?
I have, and I am excited about it. Well, first and foremost, that the Academy of Nutrition and Dietetics has this practice group, and we're integrating with the Obesity Society because oftentimes we sometimes function in a silo. And as we know, treating overweight and obesity is a team approach. With your background and your PhD from the psychological aspect, our dietetics background, the treating perspective from a medical background, it's really impressive to see our organization blend with TOS and give us this opportunity to have a sponsored talk that highlights one cog of that wheel, right, of that treatment team. And
Right.
I'm looking forward to that. And we can get into the topic, especially because it is not a one size fits all treatment. And I've been saying this my whole career. It's individualized for the patient, but also a team approach for the caregivers. But I'd love to hear your comments on it. I can certainly comment more. I'm passionate about it and think it'll be a good
Yeah.
session.
Well, I think for me, in working with patients who've had weight loss surgery over the years, I've really come to appreciate the importance of it being individualized, but also, all of the things that I thought being a dietitian was going to be about was, oh, I'm going to learn the best way to eat, and I'm going to tell everybody about it, and they're going to follow it, and they're going to do it. And that is not the case. Spoiler
Right.
alert. um,
Right.
and so I think, recognizing that, there may be some best ways and best diets. And I think that language gets people excited sometimes, but I really kind of come back to the evidence-based practice approach where you're integrating sort of best evidence at the time along with provider experience, but really taking the patient into account for their values and all of that. And so for me, not only is individualized care important, but it's how sustainable is something. So
Exactly.
so what if someone learns how to do, this perfect way of eating for a couple months, they lose some weight, like, are they going to be able to keep that off long term? I think that's really important to me.
Right. And I think you hit the nail on the head when you made it about the patient. Even though we're all in this because we want to treat and help patients, sometimes we forget and we get really excited, like, well, this is the best diet and here's data on it. Or, just friends and family will ask me, well, what diet should I follow? What's the latest fad? And I never have an answer for that because there isn't a one size fits all. And yes, you're correct. Are there diets that work per se? yes, you will lose weight on some of them. However, is that sustainable? Is that healthy? It's short term, and you're not really learning the lifestyle and the education regarding the choices that you're making. And giving that obese is a disease state, we want to make sure we're treating it. And by doing something short term just to see quick results is not necessarily treating it. And by providing something that is more, comprehensive but individualized with what the patient wants and likes, then hopefully you'll have, greater luck with that in terms of sticking to it longer and making it part of your lifestyle. I've looked at diets and I think I can never follow that. I don't even like half the food that they are suggesting that you eat. So for dietitians, it's obviously important for us to understand, what do you like as a patient? What are you willing to eat? What are favorite foods, things to avoid? How do you prepare foods? What's your cultural preference, religious preferences? I feel all of that is forgotten, and people want like the quick fix on a piece of paper. And never in my life have I just given out a diet on a piece of paper. It doesn't work that way.
Yeah.
And I'm really happy to see that they're talking about these low structure diets and how that can really be incorporated and make it more about the individual.
Yeah. Well, and that kind of leads me to another session that I saw. I've heard a little bit more about this, but I think, from our sort of bench science colleagues, one of the reasons I like this meeting is going to learn about, what's coming down, the pike. We've had for so long a real gap in treatment options. There was, some dietary, behavioral things you could do. There was surgery, but the medication kind of component in that treatment gap had been missing. And so, as most people know, we've had a lot more advances in the past several years with the GLP-1 agonists and some of these injectable medications that work for diabetes and weight loss. I saw a session on, and I always have to look at it, it's called bimagrumab. It's a new drug that they're looking at. I've heard a little bit of buzz about it. The study that, an oral presentation that I'm hoping to go to, talks a little bit about a mice study, and you definitely have more knowledge about all this, but they talk about how not only when this drug combined with the semaglutide, the GLP-1 agonist, when they're combined, people are able to not only just lose fat, but also gain or build their muscle. And so, kind of talking about sustainable long-term diets, we know that when people do go through weight loss interventions and with some of these medications, one of the concerns is that if you're losing weight, that it matters where you're losing it from. So it's not just, okay, weight loss, any weight loss is good. We don't want to be losing it from our lean muscle, our lean body mass. We don't want to lose it from our bone and our water and all of these other areas. We wish it could be lost just from fat. And so to hear that there is a medication being studied that actually builds the muscle mass is super exciting to me.
Yeah, I saw that as well, and I definitely want to swing by that poster session and ask a few more detailed questions to the presenter and the authors. Like you mentioned, it was a mice study, or what we say a preclinical study, and they did look at semaglutide with bimagrumab. And the interesting component that, like you mentioned, is it's exciting that we do have more weight loss treatment options now. We've had very little in the past, and they show a tremendous amount of efficacy in terms of percent fat mass loss. But like you mentioned, you're also losing muscle with that. And so this preclinical study, there's some sort of unique mechanism of action, and they didn't get into the details in just the abstract. So I'd love to talk with the authors on that, where they have the combined, the two drugs together, and they've shown they can actually preserve lean body mass, which is great, but not only preserve lean body mass, increase it.
Right.
So that's really compelling, and I'd love to learn more about that data. I did some additional reading on that, and I did see Stephen Heimfeld did actually publish about a year ago in JAMA something similar in patients with type 2 diabetes. And the same thing, they saw preservation of lean body mass as well as an increase in fat mass loss. So this is something I think we'll probably hear a little bit more about in the future, even though it's at its infancy stages. I think it's good that we keep our eye on it.
Yeah, it's exciting just to have some better options. When we sort of came up in our training, there weren't very many options. And so to know that there's some, efficacious meds out there that are actually helping, I think is great.
Mhm.
And then
Yeah.
another sort of session that I think might sort of tie into this too is, we have medications, we have nutrition interventions, but obviously since COVID, we're seeing a lot more of like virtual applications of where people are visiting their providers. And so, me, I'm always sort of interested in how stigma and bias affects that. And so I know something you're involved with was looking at stigma and how that relates to people coming back to their in-person doctor visits. So I don't know if you
Yeah,
have any more info on that one for
I
me.
do. Yeah, I can share a poster presentation that I'm involved with that we'll have at Obesity Week. And I wanted to quote Donna Ryan at the last conference we were at the OMA conference, when she said, now we have more tools in the toolbox. And she even quoted, we have some power tools, but when you're building a house, right, you need more than one tool. You don't just need a power tool. So I really loved her quote that we are gaining more tools in the toolbox to treat overweight and obesity. So I just love that quote. And, along those lines, like you were mentioning, there's a lot of folks who feel stigmatized. Obesity is a stigmatized disease, very similar to mental health and sexual health that there were previously stigmatized, but some of that stigmatization has come down. And we were interested in learning about patients who go to telehealth providers to have treatment options for overweight and obesity. And we looked at about 380 patients in a direct-to-consumer telehealth group that we partner with to find out why are patients seeking care for obesity through telehealth versus traditional route. And the number one reason in the survey was they felt judged by their in-person healthcare provider. Not only do patients with overweight and obesity feel stigma just from friends, family, lay folks on the street,
Or that office environment.
or the office environment, you name it, anywhere, sitting on an airplane, you name it. The fact that the reason that they felt judged by their healthcare provider is someone they should be trusted to go with their concerns and disease states, made them feel so uncomfortable that they chose to go telehealth route where it was more personalized. They could be on the phone. And really, we found that patients who did this route actually had more success and they felt less judged. So unfortunately, there's just a lot of stigma that still is being experienced from in-person provider, and hopefully we can reduce that. Luckily, for those who feel that way, not making an excuse for the providers, there is an outlet for them and they can use telehealth where they might feel more comfortable sharing their experiences, and they have options then for treatment. So I think that's extremely positive, and I'm happy to see that there are tools in the toolbox, as Donna Ryan said, for these patients, that they have other places to go if they feel stigmatized.
Yeah, well, I think we'll probably see a lot on virtual now that there's been enough time to sort of study how people have done, in interventions there that have been more virtual. So
Absolutely.
hopefully we'll get to hear a lot more about that. And so, yeah, well, let's wrap up. And I think definitely we've got a lot to do. We can probably tag team some of these talks and go to
Yes.
ones that are concurrent and let each other know how they go. But definitely follow us along on, I think LinkedIn is probably one of the favorite places to talk about what we've learned. And of course, I love to live tweet during conferences and kind of get some photos while we're going to help me remember what we're learning. So thanks again for joining us, and I'll see you in San Diego.
Great. Thanks, Nina. Bye.
Bye.